Well, thanks again, Patrick, and good morning, church. I really appreciate the opportunity to be here and talk about this today. And of course, you know, every Sunday we don't go to church necessarily to hear about medical things and vaccine science. But of course, this is an issue of really primary importance to all of us. I think this is a pretty health-conscious community. But really, the whole world has questions about COVID right now and COVID vaccines. And you know, for me personally, being an infectious disease specialist and an educator, you know, there are times in your life where you're not totally sure necessarily what God's purpose for you is, and you wander around kind of wondering, like, what am I doing here? What am I supposed to be doing? This is not that time for me. It's pretty clear what I'm supposed to be doing, and I can do it like Esther, or I can hide under a vine like Jonah and complain about it, so I'm going to try to go along more the lines of the former here. So I really wanted to address questions today. I've been getting a lot of the same kinds of questions. I've done multiple town halls already with the community and with FAMC staff and kind of our beneficiaries and so forth. But you know, the purpose of this really today is just to give you better information. So you may already have decided in your mind you want to take the COVID vaccine when it's available to you. And that's great, but really every one of us is in the position to you know, be part of a community to other people. And so each one of us on our social media or through our regular communities encounters people with various questions. And so the better informed you all are, the better you can make your own decisions, but also the better you can educate other people. So just to start off, you know, what are these vaccines about? There are two vaccines that are currently available with an emergency use authorization from the FDA. Now, what does an emergency use authorization even mean? Basically, this is what happens when the FDA concludes that there is enough science to support the safety and efficacy of a vaccine or another drug to expedite its arrival to the market. It's actually, the rigor of the science is very similar to what you would see with a regular licensure, but clearly these were on an accelerated timeline because of the public health emergency. So emergency use authorization, both of these vaccines, there's the Pfizer and the Moderna vaccine, which are currently available. Both of those are mRNA vaccines. So this is a relatively new vaccine technology. What it does is it takes messenger RNA, which is essentially almost like an email, but more like a Snapchat, because an email, you know, lasts forever, but a Snapchat is something that sort of disintegrates pretty quick. And it's a message, essentially, a genetic message to your own proteins in your cell about how to make spike proteins. Spike protein is, you've seen pictures of coronavirus with like these knobby things on the outside of it. That's the spike protein, and that is what facilitates the virus attachment to the cell and then entry into the cell. So we've also seen with natural infection with COVID, people make antibodies to that spike protein after the fact. So when your own body can create that spike protein through use of this messenger RNA, then you can make antibodies for it, and your cells can be ready for that event. When they see COVID in the future, it'll be ready and, you know, not let that through. We haven't really had messenger RNA vaccines before. They've been kind of in research studies for a long time, actually. But some of the difficulties have been just logistical, because messenger RNA degrades very quickly. I used to do research with this when I was a medical student, actually, and it was a super big hassle because, you know, you had to store it in a negative 80-degree freezer, and then you would have to reconstitute it and thaw it and mess with it, and then was it going to even be stable enough or not to work in a cell? That was the problem, is that it disintegrates so quickly that it's really tough to get it into human cells. So what they did with these two technologies, the Moderna and the Pfizer, is they created kind of a fat envelope around it so that it can actually be stable and get into the cells. So those are the two vaccines that are available. There's another one, the Johnson & Johnson vaccine, that is approaching, you know, they're going to probably submit for their AUA here in the next couple of weeks, and that one's a little bit different. So those are the two that we have available right now. The thing that's really exciting to infectious disease docs and people who do immunology is just how efficacious these vaccines look to be. So at the beginning of this, back in March, actually, I was kind of skeptical. I was like, all right, we're going to get a vaccine. It's going to be done in 6 months. It's going to work great. I'll believe it when I see it. Like, in God I trust, but everyone else has to show me the data. And I was like, I'm going to look at it myself, because there's some lines that I'm not going to cross either as a leader for recommending things to other people if I don't think that it's good. So initially, the line in the sand that the FDA drew with regard to efficacy was 50%. If it was 50% effective, then they were going to consider it for licensure or for an EUA. And these two that are available on the market are 95% effective, which far exceeds the efficacy of most other vaccines that we have, and really, was one of those things that if you see the graph of it, the graph of who got the vaccine, and then who got placebo in the clinical trials and then got COVID afterwards, you don't even need statistics to be able to look at that. I mean, obviously they did statistical analysis on it and proved that it was 95% effective, but this is not a subtle finding. And that efficacy was measured at about a week after the second dose. So both of these vaccines are a 2-dose series. You get the second dose of the Pfizer at 21 days and of the Moderna at 28 days afterwards. And then efficacy is really measured after that 1 week after the second dose. But you start to see a difference in COVID infections about 10 to 12 days after the first dose. So the second dose is what's been studied and it's recommended, and that's what we know, that we have at least a few months of durable protection afterwards. But so far that looks really good. I get questions about how long is this immunity going to last. We really don't know yet. That's one of the big questions that we won't know until we have several more months and maybe years of follow-up data. But there's at least 4 months of follow-up so far from these clinical trials, and it looks good so far in terms of follow-up. And then side effects, kind of symptoms people get afterwards, are pretty similar to what we see with other vaccines. Sore arm, clearly, you can get fatigue, headache, low-grade fever, chills, things like that. More common after the second dose than the first. I've had 2 doses. The first one, my arm was kind of sore for a day, and the second one, 24 hours later, I kind of had low-grade fever, chills, felt like I was coming down with something, and then cleared that after the next day. So pretty similar to like a shingles vaccine, I'm told. I haven't had a shingles vaccine, but that's what I've heard it best compared to. And then allergic reactions are rare. So far, they're tracking about 1 per every 100,000 will get a serious allergic reaction like anaphylaxis. This, again, is kind of on the order of some other vaccines, a little bit more common than what we see with a flu vaccine. What's driving that is, it looks like a couple of the components, the lipid components, those fat layers around the messenger RNA. So if you have an allergy to polyethylene glycol or polysorbate, those are the 2 ingredients that are thought to really drive those allergic reactions. And it's because of allergic reactions and the potential for that really everybody's monitored for a few minutes after they get the vaccine, 15 minutes typically. But if you have a history of severe allergies, one of the questions from Facebook was, I've had anaphylactic shock from a prescription drug and have had reactions to generic drug additives, but never a reaction to the flu or any other vaccine. Should I take the vaccine? So if you've had an anaphylactic reaction to another vaccine or an injectable drug in particular, they'll watch you for 30 minutes after you get your dose. And every vaccine site is required to be equipped with all the usual stuff that you need to treat anaphylaxis. And that's kind of what we've seen for adverse events so far, just the symptoms that your immune system is responding to the vaccine like it should, and then those rare allergic reactions. In the trial for the Pfizer product, there were a few cases of Bell's palsy in the vaccine group. There were also some cases in the placebo group, but they weren't any more common than what we see just in the baseline populations, so no clear association there. And there weren't any cases of Guillain-Barré syndrome or transverse myelitis, which are kind of spinal cord or nerve inflammatory diseases that sometimes we see with immune activation. They haven't seen that yet. Sometimes those things come out later after you've gotten many millions of doses into the population, because they're pretty rare at baseline, so it takes a lot of cases to be able to really tell, is this more common than what we would see in people that hadn't gotten the vaccine. So time will tell if there's anything that's a rare adverse event, but so far so good, and there have been about 30 million doses of these vaccines administered around the world so far, which is, I think the administration's goal was to get 20 million doses into Americans by the end of 2020. That didn't happen. But every day we're accumulating kind of more person months of follow-up with what happens with this, and so far it looks good. I've been monologuing for a minute, so I'm going to ask you, I have a bunch of other FAQs because I know the questions that people tend to ask me about this, but if there are any questions here in the audience or on Facebook so far, I'm happy to take those. Yes, sir.
Dr. Yoon, how careful do we need to be even after the injections?
Yes, that's a great question. That's a question that I get, how careful do I need to be, and what does this change for me kind of immediately after I get the vaccine? And the answer for now really is we're going to keep doing everything that we're already doing. We're washing our hands. We're still wearing masks. We're still quarantining if we come to close contact with somebody that had COVID. And the reason for this primarily is that there's still so much bulk of COVID out there in the environment and in the community that we're really none of us safe until most of us are safe at least. There's been a lot of talk and question too about, proving that the vaccine, what it's been proven to do really definitively is decrease disease in people that got the vaccine. So if you get the vaccine, you're 95% less likely to have COVID-related disease, to be sick with COVID, and to have severe disease, like to end up in the ICU or having a bad outcome. So those two things are unequivocal. What's harder to study and what wasn't in the clinical trials that they did, in the interest of expediency, was a lot of transmission-based science and then looking at asymptomatic infections. So there are little subgroups that have looked at asymptomatic infections, just swabbing people every week to see if COVID ends up there. There was a branch of the Moderna study that looked at that, and it did look like they saw a reduction in asymptomatic infections. But we won't really know for some time, the extent to which these vaccines reduce that transmission, which is really, what the masks and things like that are about. Now, do I think it's going to reduce transmission? Yeah. Basically, every vaccine ends up reducing transmission. If you reduce disease and you reduce symptoms and you reduce viral load and you reduce infection, then you end up reducing transmission. But because the stakes are so high with this and we're in the middle of a public health crisis, we really don't want to make an assumption about that and be wrong and then have, some kind of a big disaster related to ongoing disease transmission. So for now, everybody's going to still remain in the same protective posture until we get to a place where, herd immunity is a thing, and really where we get to a place where we see transmission being a rare event in the community. Right now in the United States and in San Antonio, it's busy, it's raining outside with COVID, and you're going to get wet if you go outside without an umbrella. Yesterday I think it was 2,400 cases or something like that, new cases in San Antonio, and another 180 or so hospitalizations just yesterday. I saw a figure that we have crested, we're about to crest the 400,000 deaths in the United States from COVID. This week we'll get there, which, and 25 million cases, which is just, mind-boggling considering we don't even capture a fraction of them. So until we start seeing those figures slow down, and then the positivity rate, right now in the community in San Antonio, about 1 out of every 5 COVID tests is positive, about 20%. And we really want to see it like less than 5% for a while before we are like, okay, things are cool, maybe I can start to relax a little bit. Yes, ma'am.
I've always heard about our DNA, but I've never heard about RNA. Can you explain to me what that is?
Yeah, so the question is about what's the difference between DNA and RNA. So DNA is your permanent genetic makeup. It's really the code for, what is an organism made out of? What are all those proteins going to consist of? And DNA is what is in the nucleus of the cell, and really is what's passed down, from generation to generation. RNA is the message basically from DNA to the components, the machinery in the cells that make the proteins. So the DNA doesn't interact with those proteins directly. It communicates through this RNA, which is almost like a shadow or a mirror image of the DNA. And whereas DNA is pretty permanent and lasts, RNA is really temporary and degrades very quickly. One thing I didn't mention with regard to the vaccine is that the RNA doesn't get into the nucleus of the cell. It doesn't interact with your DNA in any way. That's one of those concerns that people sometimes have is this going to mess up my DNA? No, it doesn't mess with your DNA. It doesn't interact with your DNA at all, and it can't be incorporated into your DNA. That's not how RNA works. There's really no mechanism to do that. It's a great question. Other questions from the audience? Yes, ma'am.
Since this is a new methodology, I guess, using RNA, do they know what the long-term 5-10-year impact can be since we've never done it before?
Yes, ma'am. So the question is about, what about long-term side effects, and do we know? Because we don't have widespread adoption of a messenger RNA vaccine before, that's one of those question marks that I think a lot of people have. What I can tell you is that vaccines in general, if there's going to be long-term side effects, it's because of a short-term complication. So I'm not tracking any vaccine that produces a side effect that wouldn't manifest within about a month after the vaccine. There have been kind of disinformation, there's been concern about things like autism or whatever, but autism isn't caused by vaccines, and it's been proven. So that is something that, there wouldn't really be a biological basis for why this would occur. If you got Guillain-Barré syndrome or some kind of inflammatory neurologic event that happened right after your vaccine, then yeah, you could have long-term effects from that. But because this messenger RNA degrades very quickly, we don't really have a biological basis for what that would look like. One thing that we will be keeping an eye on is because your immune system and your antibody response to the vaccine is very similar to what you would get after a natural infection, is looking at, have we seen so far any kind of immune-mediated long-term complications from COVID, from having those antibodies? And, while people have long-term, sometimes long-haul kinds of symptoms after their original infection because of lung damage or heart damage or whatever, that's a separate issue. But from the antibodies themselves, nobody's seen like a big signal for, autoimmune diseases or fertility problems. That's another one on the internet that's a pretty popular fiction, is that this will cause fertility problems, but there's no evidence to support that, and it's one of those nuggets of disinformation, actually, that kind of percolates up whenever a new vaccine comes along. This is not the first time we've heard that. It kind of pops its little tentacles up through the cracks in the concrete every time there's a new vaccine that comes along. Yes, sir.
Well, what is being done to communicate the safety of the vaccine? I mean, we have a large percentage of the population, like 21%, that say they won't get the vaccine.
Yes, sir. So this is what's being done. This is one of the things, right? I mean, there's a lot of information that's out there on the internet that is, getting messaged out from all kinds of different organizations. I think the trouble is there's so much, the signal to noise ratio on the internet is problematic. And it's really difficult for a lot of people to know what to trust if they see something on the news, or they see something on the internet, or they hear something on the radio. If you don't have a background in science and you can't look at the data yourself and understand what's going on, it can be really challenging for people to sort that out. So, that's why I'm here, honestly, is to try to make sure that, just ordinary citizens have the opportunity to hear, and all of us really involved with public health or infectious diseases or vaccine science or immunology or primary care. It's on us to try to educate our community as best we can. And it's on you, too, after you learn a little bit, is to make sure that you pass that knowledge along. Other questions from here? I get questions sometimes about this vaccine because there's some new emerging strains that you might hear about in the
Yes,
news.
right.
There are a couple of strains that have popped up recently that have caused concern for either increased ability to transmit, like they're more transmissible, they're more contagious than the original, or that maybe that they would be able to produce some variant that would escape antibody response. And would these vaccines be effective against those? We don't have really a lot of data yet. The preliminary data looks encouraging, but we'll find out more, in the coming months about that. I think one thing that's important to point out is that, we see strains arise because of unmitigated transmission. This is what natural selection looks like and evolution on a real-time basis. If you want to see how that works, what you do is you get millions and millions and millions of translations, and then you can see slippage in the genetic material of the virus. Because viruses, really, it's not economical for them to be overly meticulous with how well their RNA gets preserved from generation to generation. Viruses are kind of sloppy in that regard. And so you never really see the same exact virus for very long because they always mutate a little bit. And so what we're going to find out with these new strains is really, are those mutations going to be relevant or not? And it's hard to know so far, but we think the vaccine, based on preliminary data will be good for all the strains that we know about so far. And everything that we do to try to slow down that transmission, reduces the likelihood that we'll see those new strains. There was a question from the internet about, how important is it to our immune system to eat healthy, exercise, and get outside in the fresh air and sunlight, and how can we balance that with the premise that we need to stay at home? Yeah, so great question. Immunity is about a lot of things. There's, broadly speaking, a couple of arms to the immune system. There's the adaptive immune system, which is the learning bit, and that's what I'm talking about, where your body has to encounter a specific virus or a bacteria to be familiar enough with it so that the next time it comes around, it's not going to get past your defenses. And then there's the innate immune system, which is like what we share with starfish and earthworms and fungus and every other thing. That is, very well biologically preserved and just helps us to not drop dead from, whatever every single day. And things like exercise and good nutrition and sleep are kind of fundamental for both of those things. Like, the better you can do with taking care of yourself, obviously, the better it is for just about everything in your life. Is it enough to keep you from getting COVID or getting severe COVID? Not really. I mean, I think all of us have experiences in healthcare with taking care of people that are younger than us that have no comorbidities at all, that are really in a bad way. We do know that who's most at risk for COVID, severe COVID infections, are older individuals. It really increases with age, and then people with certain comorbidities like heart disease, COPD, diabetes, compromised immune systems like transplants and things like that. Pregnancy is another one that increases risk for COVID. So, absolutely all of us need to be doing what we can do to try to optimize our nutrition and exercise and sleep and all of that. And as far as, staying at home, obviously, like most of the time if you're exercising outside, you're in the fresh air by yourself anyway. I went running this morning. I don't think, there's any risk of COVID of me going running at sunrise at the dam by myself with no mask on. So if you want to join me, you're welcome to. Otherwise, find what you can do outside safely to get your exercise. That reminded me of another question that I get a lot. What about pregnancy and lactation? Can those women, get the COVID vaccine? And while pregnant women were not included in these trials that they have done, quite a number of them became pregnant kind of during the course of the study. And so far there haven't been any issues related to that. And there's really no reason that we would see it. The messenger RNA, when you get the vaccine, kind of all that stuff that's happening is happening very locally. We really don't see, there's no live virus that would get into your bloodstream and cause a problem or something like that. And because COVID is of significant concern with pregnant women in particular, the American College of Obstetrics and Gynecology has come out saying it shouldn't be withheld from pregnant women. When it's their turn to get it, then you know, they should be able to get it. Same with breastfeeding women. Other questions from the community or from Facebook? Anyone? If not, I'll go to my list of the other things that people ask me about.
Just an observation, I was fascinated to hear, Heather, that this type of investigation for this vaccine is not new. That we had people working on it with the SARS virus, just so many of those burned so hot
Exactly.
that the funding ran out. But this RNA research has been the heroes of this whole research are people that have been at it for a while.
For sure. Yeah, so Patrick brings up the, you know, how did they get this across the finish line so quickly? And it's really because of the foundation of work that we have had, not just with mRNA vaccine technology, but with coronavirus vaccine technology. So we've had a couple of dress rehearsals with bad coronaviruses before in the last couple of decades. So SARS, some of you may remember from the news, and then MERS coronavirus was the one more recently that kind of originated out of the Middle East. And both of these were, you know, pretty similar origin stories to what we've seen with SARS-CoV-2. Every year, you know, I'm an ID doctor, and every year we go to our national meeting before 2020, and it would be like, you know, prophets, we're overdue for a pandemic, it's going to be a coronavirus, it's going to be of animal origin from what we term a zoonotic crossover event. You know, humans contact animals, like all kind of animals, all the time, and it's one small step from an animal to a human, but it's a giant leap from an animal disease to a human disease. So, so this is a thing that has been seen and borne out over and over again with these coronaviruses. So nobody in the ID community was particularly surprised when this happened. But because of those events, because of SARS and MERS coronavirus being of pandemic potential, really a lot of work went in at the time to try to generate vaccine candidates. And they did generate vaccine candidates. It's just there was no market for them because SARS was gone by the time they came up with a vaccine. So yeah, no, clearly somebody will get a Nobel Prize out of this for work that they did with no funding, you know, 2 decades ago. But that's one of the reasons, you know, people ask me, don't you think this, you know, was rushed too quickly? But one thing I didn't even quite understand at the beginning of this was how much foundation work was done here. And then this is also what we see, you know, this is what science would look like for anything if the whole world was interested in the outcome of it, you know. There's just only so much funding and effort into science to go around at any given time. But everybody's priority in 2020 was getting some kind of a COVID vaccine that was going to work and be safe and effective and all of that. The other reason that it was able to conduct these trials so quickly compared to other vaccine trials is that there's no shortage of endpoints. So what you need to be able to evaluate something scientifically and tell a difference between those who got placebo or just a saltwater injection and those who got the actual vaccine is you need enough people to actually get COVID to prove that the thing works. And because everybody's getting COVID all the time, every day, you know, those people who got a saltwater injection, there were enough of them within a couple of months to be able to say, yep, okay, we got enough data, it looks good, and looks like this is going to work.
I've got a question. Why is this virus so much more virulent than, say, SARS or something else?
Yeah, the question is about virulence and why is this one so much more virulent than SARS? Virulence really refers to the deadliness of a virus. And I don't know that this one is necessarily more virulent than SARS. We do tend to see over time, if there's a zoonotic crossover event like this where an animal disease becomes a human disease, like over years typically it will become less virulent. And part of this is because it tends to be more efficient for transmission if you have less severe disease. Because if you're smoked and you're dying at home and you're dying in the hospital of whatever your bad disease is, you're not wandering around the community infecting everybody. Like sort of the golden the brass ring, the coin of the realm if you're a virus is to cause completely asymptomatic infection, and then you can just replicate and nobody minds and everybody can get disease. So a lot of viruses that we've been dealing with, like herpes viruses, okay? Herpes viruses, you're gonna get some of them by the time you're a toddler, a preschooler, and you just go ahead and live your life, and like most of them you don't even know that you have, and you've never heard of them because they don't cause anybody any problems really unless you have a transplant. So that's what you want to do if you're a virus. But this, typically when we see a new virus in a population that has no pre-existing immunity at all, that's when we see bad outcomes because really that adaptive arm of the immune system has no experience with it. So, you're kind of on your own with you and your earthworm, starfish, innate immune system to try to overcome this thing.
We had a question online. I've heard that you should get the vaccine doses in opposite arms. How important or true is that?
That's really not a concern. I got both of mine in my left arm because I'm right arm dominant, and if I had a big sore arm, I wanted to still be able to cook dinner. Really the only thing about, getting the vaccine is you want to get the second dose the same product as the first dose. And out in the community right now, both of those vaccines are available, both the Pfizer and the Moderna. Typically, if you get an appointment and you go in and you get your Pfizer shot or whatever, they're going to book you on the spot for your second appointment so that you will get the Pfizer shot. But nobody has studied like mixing and matching the different vaccine products, so that's really not recommended. Although if it happened, we would be like, okay, I guess that's okay. We wouldn't really recommend restarting any kind of a series or anything like that. Sometimes I get questions about, should I take prophylactic ibuprofen or something like that? There's a theoretical idea that taking anti-inflammatories like that might blunt the immune response a little bit. So in general, if you feel terrible and you need to go to sleep and it's nighttime and you have a fever, go ahead and take your ibuprofen, but we're not recommending really prophylactic ibuprofen or Tylenol just in case you were to get symptoms from it. I get questions about other vaccines and timing. So right now the recommendation is 14 days before or after. Like if you got a shingles shot, you should wait 14 days ideally to get your COVID series started and vice versa. Any other questions from here in the room or on Facebook? I wish I had more to tell you about process things because you may be like, yeah, I'm all in, give me my vaccine, where can I go get it? And that's a little bit of a work in progress. There have been a few different avenues to get this in the city so far. One is through the city, really at the Alamo Dome. They have been opening up appointments for this that are gone like within 6 minutes or something like that. I think it was a phone-based appointment system. University Hospital has a mass vaccination event going on at Wonderland of the Americas Mall. And they had an initial release of appointments around the 1st of January, and those were snapped up within a few hours. They are doing some standby vaccination because what happens with these vaccines is you only have a limited window of time. Like the Pfizer vaccine has to be stored at -80°C, which is a special freezer that not a lot of places have. And then after it's thawed, you only have 5 days to give it. But after it's reconstituted and it's like mixed up and ready to go, you only have 6 hours to get it into a human. So nobody wants to let these doses go to waste. And so most of the time, if there's appointments, there's going to be some no-shows, people that didn't end up coming in because of whatever. So everybody's kind of strategy is to get those doses into arms at the end of the day. So some of these places, there are ways to get standby vaccine. But for now, the city, University Hospital, and then WellMed are the other kind of big processes in the community to try to get on a list to get a COVID vaccine. And then in terms of priority groups, what Texas is doing really is after healthcare workers and first responders and kind of essential personnel, it's over 65 and then under 65 with one of these high-risk comorbidities. that might not sound like a lot of people, but it's actually the majority of the population. The majority of people between the ages of 16 and 65 have some kind of comorbidity. And that speaks to how common these comorbidities, actually obesity is one of them. So if you have a BMI of greater than 30, you're in that risk group for severe COVID. So there's just not a ton of supply yet to take care of all the demand of people that want a COVID vaccine. And then I get questions about children. So of those two vaccines, the Pfizer vaccine is authorized for down to age 16. The Moderna vaccine is authorized for down to age 18. There are trials going on with adolescents and younger children, but right now there's no vaccine available for a child under the age of 16.
We have a question. Once you've had COVID, what are the personal care items that you need to replace, or does it matter? Example, toothbrush, lip balm, etc.
That's a good question. Really, there's not unless it's a shared item, that you're going to be sharing with other people, there's really not a recommendation. You're not going to reinfect yourself in your toothbrush or your chapstick or something like that. I do get the question, I already had COVID, can I still get the vaccine, or should I still get the vaccine? And the answer is yes. The only real time that you wouldn't is if you were actively sick with COVID and you were still on isolation. If you're still on isolation, just go ahead and finish out your isolation and then come in for your first dose or your second dose, which might be a little bit delayed. That's okay. Just don't come in if you're actively sick with COVID. But people who have had COVID certainly can get the vaccine. And after about 90 days after your COVID infection, you're sort of presumed to still be at risk for reinfection. So we are definitely offering it to that category. Let me see if there's one more that's common. Okay, is one vaccine preferable to the other for specific patients? That's a pretty common one. The answer is no. And one of the really gorgeous things about these trials that excited a lot of us is that they were pretty diverse. So, what we've seen in terms of the people that actually were involved with the trials, and they always conduct subgroup analyses to try to figure out, is it more or less effective in younger people than it is in older people, or in, one ethnic group or gender or something. And so far, it looks really good across all the age groups tested in terms of efficacy and all the demographic groups. And that's really important because, we're not all equally afflicted. And older people and actually Black and Latinx and others, persons of color are higher risk groups. Those communities really, for a lot of reasons, have been disproportionately afflicted by this pandemic. So it's important to know that these vaccines are good in all those populations. So that's the end of the questions. But thank you again for giving me the opportunity to speak here today. I certainly am available, of course, offline if you get another question or you had a question that you didn't want to ask about. Or you have a purse that you left here, because this one isn't mine.
Oh, it's not yours?
No.
Sally's.
Oh.
But thank you very much.